Welcome back to the channel. Today's topic is chronic obstructive pulmonary disease. COPD is a common preventable and treatable disease characterized by persistent respiratory symptom and airflow limitation due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. It includes chronic bronchitis and emphysema. Epidemiology: 1 in 10 people over 40 years may have COPD. It is the third leading cause of death worldwide. Risk factor and etiology: cigarette smoking, most important; environment like biomass fuel, occupational dust, air pollution; genetic, alpha-1 antitrypsin deficiency; other, second-hand smoke; respiratory infection in childhood; early life exposure to maternal smoking can impair lung development. Pathophysiology: airflow obstruction due to small airway disease and emphysema; chronic inflammation involving macrophage, neutrophil, T lymphocyte, protease, antiprotease imbalance; oxidant antioxidant imbalance; emphysema, 3 varieties: centilobular, panlobular and paraseptal; gas exchange abnormalities. This is the picture. Upper one is the chronic bronchitis with luminal narrowing, lower one showing the emphysema with interalveolar septal damage. Clinical features: symptom: chronic cough, sputum production, progressive dyspnea, wheezing, chest tightness and fatigue. Signs: prolonged expiratory phase, rhonchi mostly expiratory phase, hyperinflated or barrel chest, use of accessory muscles. Cyanosis, corpuscular cachexia in advanced disease. Phenotype: blue bloater, chronic bronchitis showing cyanosis and edema, pink purpur, emphysema patient showing thin posture with pursed lip breathing. Investigation: FEV1-FVC ratio is less than 0.7 after bronchodilator. Severity is graded using gold system. Post bronchodilator FEV1 80 or more is the mild, 79 to 50 moderate, 49 to 30 severe, less than 30 very severe. This is the volume time curve of COPD showing low FEV1. Obviously, the FEV1-FVC ratio will be low. In the right side, we see characteristic scooping, the descending limb of the expiratory loop. CAT score, COPD assessment score, 8 questionnaire: cough, phlegm, chest tightness, breathlessness, activity limitation, confidence, sleep and energy. Each carries score 0 to 5, total score 0 to 40. 0 to 10 is the low impact mild symptom, above 10 is medium, high and very high. MMRC grade, Modified Medical Research Council grade 0, dyspnea only with strenuous exercise; grade 1, dyspnea when hurrying on level ground or walking up a slight hill; grade 2, walks slower than people of the same age on level ground because of breathlessness or to stop for breath when walking at its own pace; grade 3, stop for breath after walking 100 meters or after a few minutes on level ground; grade 4, too breathless to have leave the house or breathless when dressing or undressing. Used to categorize symptom burden in COPD like CAT score according to gold guideline. MMRC 0 to 1 low symptom burden, 2 or more high symptom burden. Management considers symptom burden using CAT or MMRC score and exacerbation history. This creates the category A, B and E. In the left side, we see the exacerbation risk. Low risk is 0 to 1 moderate exacerbation and no hospitalization in the past year. High risk, 2 or more moderate exacerbation or 1 or more hospitalization in the past year. This is the exacerbation category. And the symptom category: low symptom when MMRC 0 to 1 or CAT less than 10, and high symptom when MMRC 2 or more or CAT 10 or more, depending upon all group A, group B and group E. Test: chest X-ray, CT, hyperinflammation, emphysematous chest, alpha-1 antitrypsin level, ABG in advanced disease, CBC for eosinophil count. This is the chest X-ray showing hyperinflated lungs. This is it's a CT scan shows emphysematous lung changes with paucity of the interalveolar septal. Management: non-pharmacological, smoking cessation, most effective vaccination, influenza pneumococcal, pulmonary rehabilitation, oxygen therapy for hypoxemia, in selected cases lung volume reduction surgery or transplantation. Pharmacologic approach: for group A, LAMA or LAVA, Group B LAMA plus LAVA, Group E LAMA plus LAVA, and ICS useful if eosinophil 300 or more. Roflumilast, azithromycin in selected cases, oral theophylline rarely used now, protein therapy, alpha-1 antitrypsin deficiency. Exacerbation treatment, bronchodilators, short-acting beta agonist with or without antimuscarinics in MDI form or in through nebulizer, systemic corticosteroid, 40 mg oral prednisolone or its equivalent only for 5 days, antibiotic if bacterial infection suspected, oxygen therapy to maintain saturation 88 to 92%, non-invasive ventilation in acute hypercapnic respiratory failure. Conclusion: COPD is progressive disease, but early diagnosis, intervention, smoking cessation can slow its course. COPD is preventable, treatable, but not fully reversible. Always think about the comorbidities like cardiovascular disease, osteoporosis, anxiety, and lung cancer. Frequent exacerbation worsen prognosis. Thank you for watching the video.